Welcome to Hacking Hypermobility Podcast.
I'm Luna.
And I'm Shelli.
And we're two bendy mamas.
Hacking Hypermobility. What are we doing?
I don't know. Should we start? Thanks for coming back for episode 3. Before we get too far into the weeds on the hypermobility diagnosis journey, we're going to take the time today to have a serious talk about the frustrations you might encounter based on our own experiences and some hacks we have developed on our own to help you along the way. Nothing's perfect, but we have some ideas.
In this episode, we're going to talk about the barriers in the diagnostic journey and that are preventing you from understanding what's causing your hypermobility disorder. And some of those barriers are more internal and some are more external to you. And so those are even harder to address. And so this is going to be a really emotionally charged conversation. So just be aware of that. Break it up into segments if you need to, if you get overwhelmed. And we're going to put together summaries and resources on our website, hackinghypermobility.com.
So due to the very nature of having a likely genetic disorder that affects many, if not all of your body systems, being a hypermobile affected human can be a very frustrating life experience. We're going to talk about those frustrations and give you some hacks for managing the things that seem to stand in your way to getting a diagnosis and the care that you need. So first, we're going to talk about those internal barriers, meaning those that are just part of our nature and common to our experience. And then we'll talk about some of the barriers external to our own bodies and minds. And while the zebra experience can be very similar, we're all different and we all cope in different ways. Primarily, we want to just allow you to give yourself the space to first, acknowledge and then be aware of the barriers to your care, but never forget that we zebras all have one thing in common. We're all strong and no one is broken on the inside.
That's right. So barriers to diagnosis. So first, we're going to talk about internal barriers, meaning those inherent to ourselves and the nature of the disorder. And so the first thing is neurodivergence. So Luna, what is neurodivergence?
So you may or may not have heard of the term neurodivergence. If you have met Shelli and I on other platforms, you've probably heard us use this term. If you're just listening for the first time, you may not have heard this, or you've maybe never heard it explained. So it's not actually a medical term. It's a term that the community of neurodivergent people created to explain the divergence in mental and neurological function from what is considered, quote, typical or, quote, normal. It references the various types of people whose neurological development and state are, quote, atypical. But truly not one version is neurotypical. It's a big variety of people and neurotypes in the world. While this isn't really a medical type of term, it was created for like-minded people to allow us to be more inclusive to these related neurotypes, but also to allow us to speak more collectively with more power. So neurodivergence is more common for those of us with inherited connective tissue disorders, with the comorbidities of both ADHD and autism spectrum disorder having been associated in medical research. And there's even theories as to why there are formal theories linking connective tissue issues and neurodivergent types such as ADHD and autism. Neurodivergence actually includes quite an extensive list of different medical diagnoses, not just ADHD and autism.
Yep. That's right. So there are also different neurotypes that present that are included under the definition of neurodivergence, but are medical in nature. So dyslexia, dyscalculia, epilepsy, hyperlexia, dyspraxia, ADHD, autism spectrum disorder, obsessive compulsive disorder. Sensory processing disorders, though not yet recognized as a diagnosis on its own, some professionals have been suggesting that it should be considered. PTSD, and even mainstream, non-mainstream, gender and sexuality identities have been included in this umbrella of neurodivergence.
So what's interesting with neurodivergence is a lot of us experience something called alexithymia. You'll see it discussed in terms of autism communication, but also it's experienced in other neurodivergencies. It's basically the inability to fully explain in the moment or ever something internal, and I'm doing this right now because I struggle with this deeply.
I have this also.
Um,
I'm glad I have a
so
name for it now because
yes, I'm glad I can explain it now. So typically you'll see this presented in someone when they have a delay in processing the world around them, whether it be processing emotions, their sensory experience. I have pretty pronounced auditory processing delays. And for me, it comes out in my speech pattern, like what I'm doing right now. But it also comes out in like trying to engage one-on-one with people, or like in school, I couldn't take verbal instruction. It did not compute. I can't hear numbers, but I'm really good at math. Those are just some examples. There's other sort of like processing delays, like we have delays or struggles interpreting pain signals, hunger signals, any sort of body input and
goodness.
signals to the brain. This is a result of the neurological differences. So one of the other common things that you see in neurodivergencies is masking. And this is this term that we use to explain a phenomenon that is almost inherent and intuitive to the neurodivergent experience growing up. We don't necessarily realize we mask. Masking just means where we try to fit in with the rest of the world. I might, like mimic someone's accent or manner of speaking and mimic their facial expressions. Typically, I have kind of people have told me I have an autism accent. So like I'm kind of monotone and flat, but also in the same hand, everybody around me growing up made fun of my rubber face and all of my expressions and being really gregarious, and like I was called a female Jim Carrey. That was a mask, and I do it really
which is
well,
hilarious because he
unfortunately.
was in the movie The Mask. Anyway,
But
sorry.
masking occurs in many different situations where we, try to fit in to protect ourselves. It's not just a neurodivergent thing, but it is almost universal with neurodivergent humans. I will say, as a side, that masking also keeps you safe practically sometimes, particularly as a disabled human or a person of color. You have to fit into the mainstream for your literal safety. But I'm also referencing, like emotional safety, that sort of thing. A lot of us also struggle with something like aphantasia, where we're unable to form mental images without having something like right there in your field of vision. Like it's a struggle to like go to the doctor and explain, well, this is exactly how I feel. This is what's happening. This is my symptom. Because when it's not happening, I forget about it. I can't describe it. I can't explain it. I can't be real clear on the details of it, that sort of thing. In autism specifically, there are related factors that impact healthcare interactions, including verbal communication skills being affected, even when you aren't masking. Sensory sensitivities that are more difficult to manage in certain environments, especially medical environments being one of those. Challenges with our body awareness, processing, and challenges with organization. So everything leading up to a doctor's visit, the actual doctor's visit, and then processing what happens after it, and then having a plan and an organization can be a challenge when you're neurodivergent. The healthcare disparities for neurodevelopmental disorders are only really beginning to be understood and studied, but it is acknowledged, it is known. I'm going to actually have us put in the show notes some links to some healthcare advocacy resources. Some are specific to autistic humans, by the way. And we would be remiss if we didn't mention the intersectionality of disability with other marginalized groups. Just going to leave that there.
So it's not uncommon for those of us who also have a physical disability to be affected by those challenges of emotional regulation and communication as well. And so it's also common for us to have depression and anxiety, right? And because that's common with everything else we're dealing with, it's easy to just put the blame, oh, well, you're depressed, you know? Other comorbid issues that come along with the connective tissue disorders are POTS, which is the postural orthostatic tachycardia syndrome, and other autonomic dysfunction. And that presents as anxiety and with anxiety. So sometimes it's hard to like break those up. The mind body disconnect. And this is something I struggled with. That is harder for you to process your emotions if your brain separates yourself from feeling those feelings. And that compounds the inability to identify the cause of your overall pain, which, as we mentioned, if you have communication issues, I mean, these are just compounding issues. So you can't articulate your symptoms clearly, and your pain perception is completely skewed because you're always in pain. So when someone asks how your pain is, like, to which pain are you referring? So there's also like the systemic disorder effects. So on top of any like brain fog that kind of overshadows all of it, right? Brain fog, that you're going to be tired, you're not going to sleep as well, you're going to have fatigue, which is going to ramp up your anxiety and depression. And so it's all connected, right? With these complex disorders, it's often difficult for us to tell our doctors just how impacted we are by all of these things, right? And how much it's impacting our loved ones as well. And so because the nature of this disorder is systemic and variable, that's the symptoms are overwhelming. Like I meet a new doctor and they're like, tell me why you're here. And it's like, I have to do this like mental calculus, like, okay, for this doctor, where should I start? So there's always changing needs, moving targets. And frankly, that's exhausting. Like you're tired of trying to find answers, right?
Healthcare fatigue is a real thing with us and avoidance, but because of all those experiences and the challenges with getting a diagnosis and help with managing your symptoms, your past healthcare experiences have likely been a little bit lacking. So you may have had inappropriate interventions, and these poor past experiences have probably resulted in a little bit or an extreme amount of increased psychological and physical distress. The understandable adoption of coping mechanisms that can sometimes become a barrier to further management. Like we put up a wall of distrust after medical mistrust that can even go into realms of medical abuse and gaslighting. The ways we've learned to cope with these challenges without support can be things that were necessary for us to cope, but may no longer be serving you well. You may need to face. So you may have a tendency to have people pleasing behaviors. That's very common in neurodivergent humans, particularly if you were assigned female at birth or living as a woman. We tend to minimize or hide our experiences. It's not as bad as it seems.
Other people have it worse than I do, so I shouldn't complain.
I'm not that disabled. I can still do this. It's not as bad as somebody else has it. It's not as bad as I'm making it out to be. I'm just anxious.
The doctor said I'm fine, so they went to med
My
school. What do I
doctor,
know?
It must all be in my head.
Yeah.
And then, that's just going to further encourage that mind body disconnect where we struggle with things like proprioception and alexithymia, that emotional disconnect from trusting your own body.
Yeah.
And that's why I said that's maybe something we need to look at on doing. So the way we have learned to cope with some of the internal ones that we've experienced, vary, of course, but some of these experiences are fairly common. There are some common systemic issues external to our experience that we encounter as well. The biggest one is just the general lack of awareness and training on the inherited connective tissue disorders and identifying hypermobility and identifying the cause and managing that in patients. So there's a lack of awareness in what we call primary care, the general type of doctors that, are doing your annual checkups and seeing you when you have an initial complaint. It's my opinion that care should be managed there for most hypermobile humans. There are no EDS specialists. There are no doctors that specialize in connective tissue disorders. Even some rheumatologists and geneticists won't see us.
No.
So, we have to call ahead and find them. There's an approach in healthcare, in medical training, there's an axiom to treat the most common cause of an issue first. But oftentimes the investigation stops there. So if you're fatigued, they assume, oh, it's a sleep disorder, it's anemia, it's depression. If you present with mental health symptoms, they're likely just going to say this is depression or this is anxiety and just give you a pill and call it a day. If you are depressed as a result of coping with a life like this and as a result of disability and pain, you may go through cycles and cycles of prescriptions
Yeah.
being told, well, let's try this one, let's try this one. And so we just stay in that pharmaceutical intervention cycle rather than investigating the cause deeper. And when you experience chronic pain and severe pain, some things start to happen with your interaction in the medical community. It can eventually put a stigma on you and your interaction with your provider. They frequently will, see a young person with pain and it's blamed on like stress, trauma, um, injuries. And you think, oh, okay, well, I hurt this. So once I get through this round of physical therapy, it'll be okay. A lot of us are diagnosed young with arthritis. Not everybody, but a lot of us are. And so they just say, oh, it's arthritis. And then on the worst end of the spectrum of dealing with a pain presenting person, you may be seen as like an addict or drug seeking when you're just complaining about pain. Even if you're not asking for pain medications, you're just saying, I'm
Right.
in pain. This is not right.
Or
This isn't
attention
alarm bell.
seeking. Oh, you
Yeah.
just, why are you
Like you're
here?
histrionic or whatever.
Yeah.
And then maybe you even shut down. Like that's what I do. Like I just avoid it.
Yeah. Yeah.
And so then it presents as, depression. A lot of us deal with what you mentioned, that, the brain fog thing. So then, you might be
It's
investigated for
on full
ADHD.
display right now.
Yeah. You might, you likely experience this. Brain fog is kind of, I would say that's one of those things that's just very general to us. If you're lucky enough to be evaluated for ADHD, you might get some interventions with that. But likely, we're going to be looking at things like nutrient deficiencies, sleep disorders, thyroid, stress. It's going to be blamed on those little things. And then the catch-all favorite, particularly for women zebras, is just lose weight. So my point in this is you may have like a stack of little diagnoses that kind of explain bits and pieces, some medications that just don't really seem to solve the problem. And it's just frustrating. And the other part of this is just getting access to care can be a challenge. Shelli, what do I mean? Like, can you give us some examples of what I mean by the access challenges to healthcare for hypermobile people?
Well, if you can find someone to actually take you as a patient, which is hard enough in and of itself, you may have to wait a while to see them. And so, and that was before the pandemic, right? And now there's quite a healthcare backlog because a lot of routine care was pushed aside during the pandemic. And that is now, in some cases, for some people, it hasn't become routine care anymore. It's like emergency care because routine care was ignored, right? We're making a dent in awareness of these disorders, but with that comes an increase in demand for services, which are already feeling the crunch, right? So it's just, I mean, unfortunately, your wait times might get worse as far as any specialists with regard to connective tissue disorders are concerned, okay? There's also limited access by where you live. I mean, where you live is a big factor. I'm really lucky. I live in the DC area. I have a lot of very good, reputable, well-respected institutions nearby that fortunately take my insurance, which takes me to the next thing, which is insurance coverage. Like your insurance carrier may not want anything to do with getting the testing done without having you jump through a bunch of other hoops first, which is, I mean, anyway. And again, as far as like where you live, tied into that is distance, which can be a factor, not just because of travel and like the cost of travel on our bodies, but the cost of travel in dollar bills, right? So just and also if you find a center that you can go to, you'll be very, very lucky if it actually is an integrated EDS type clinic, right? So there's that. Then, we're dealing with a systemic big picture problem here, right? Like with your body. And so, we were talking about the disconnect body mind, connecting that back. Like Western healthcare is not holistic, and we've got a whole body problem, and we like to um, treat it like bits and pieces, right? So like we silo it. It's like we called that when I was a consultant, we called that stovepiping, right? Like you've got all these little stacked silos, same thing. You've got, oh, your tummy, you're swallowing, you can't swallow, go see this GI person. Oh, but you've got these other nerve problems, but it seems like it's your phrenic nerve, but swallowing problems, go see a neurologist for that. But like no one stops to think like, oh, are those connected? So that's, they just anyway, it's misunderstood. You you might have an incomplete or a misdiagnosis for years. For years, I took hydroxychloroquine for inflammatory arthritis. I don't have that. I don't have it. Also, I had a B12 deficiency and they didn't want to treat me for it right away, even though I had every single symptom of a clinical B12 deficiency, but my numbers were just just in the like normal range. So they were like I had to fight for them to give me a like a $1 B12 shot. If they even understand the disorder, if they understand that it's not just, oh, you're a tall, skinny, bendy person, like if they understand that like a short statured, heavier person can have this condition also, right? So many misdiagnoses, even if you sort of get a diagnosis, right? So, like, they'll say, you know, it seems like you've got a little bit of exercise intolerance. So, manage it this way. But then they never stop to think, well, what causes that intolerance? Oh, that's POTS. Or you've got a lot of allergies, take some Benadryl. Oh, Benadryl's not working for you anymore. Switch to Claritin. Claritin. Oh, you're done with the Claritin. Time for Zyrtec. You're done with the Zyrtec. Let's get Zizal. Am I making that one up? I don't remember. There's so many. Let's not figure out why your body's responding this way. Let's just keep giving you more, band-aids. So, if you have chronic back pain and neck pain that, kind of ebbs and flows with some treatment, but they work on that, but they never actually say, why is your spinal area so unstable? They'll just say, oh, it's idiopathic. No, you just have this idiopathic condition and it's an unknown cause. And you know what? We don't know what causes it. And we're fine with not knowing. That's cool. get some imaging done. But it might not be the whole story. I had some imaging done, and the results, if they're not concerning necessarily, if you're 70 years old, okay? So I'm 45, right? So that's not there's something else going on here, right? I mentioned earlier subclinical labs, like things are a little off, but not off enough, right? They don't want to deal with that. And other symptoms that are interdependent on each other, right? So sometimes if you fix one problem, another problem crops up that's caused by a third problem, right? So there's this like, we called that the fraud triangle. When I was in graduate school and doing investigations, you need these like three things, right? But it's like a sliding scale of how much of one causes the other. And so like that's how I like to think of like the interdependent symptoms. Goodness. And then there's like, I don't know if you guys know this, but there is bias in the medical field. So what are some of those biases, Luna?
So I think a lot of us tend to just accept whatever a doctor knows and says. You've heard of the whole God complex, or, the superiority that you feel from a physician when you seek care, the automatic respect to their education and their years of experience. We tend to just defer and accept societally a doctor or medical provider's, approach and opinions. But in actuality, doctors do not treat every patient with the same level of respect and care. There are implicit biases and some that are a little more malignant in the healthcare field, same as every other field. It has been studied. There is well documented bias towards people assigned female at birth, AFAB, but it still persists. There is, of course, a great deal of weight and gender bias that, as a woman, I'm sure you've probably experienced. But there is also great mental health stigma with certain symptoms, complaints, and diagnoses when they present with a medical professional. That may be all they see, and then they discount the rest of your experience and your perception and your other complaints. And frequently, particularly women with certain symptoms, can be just written off as psychological in nature. Those of us that are marginalized in society somehow are frequently minimized or ignored when we come in with complaints, whereas another person with more social standing, acceptable neurotypes, money,
Yeah.
skin color, etc., would be respected more for their presentation. So other marginalized groups face devastating bias in healthcare as well, particularly race, class, sexuality, and gender. This type of bias can leave anyone feeling isolated, disbelieved, and lacking trust in those of the individuals that you are supposed to trust, your
Yeah.
doctors.